Very good, thank you. Good afternoon, everybody. I want to start by thanking Dr. Galan and Dr. Sotelo for inviting me here to have this talk about prostate cancer. It's a great pleasure to be here. In the first part, I'm going to talk about localized and locally advanced disease, and as part of that, I'll segue into oligometastatic disease, which is something that in recent years we've been very interested in exploring. These are my disclosures. To these, I want to add that I'm not a surgeon, I'm a medical oncologist, and all we do is just chemo and androgen deprivation, nothing fancy like what the surgeons do, and I don't have nice videos to show you, so I'll do my best not to bore you. So, when we look at the localized state of disease, most of you, I think, are surgeons, so I'm going to talk a little bit about androgen deprivation, which is mostly in early stage disease, is done in combination with radiation therapy in various settings. And so this is going to be primary radiation and with salvage radiation after radical prostatectomy. And I will touch on the idea of whether it makes sense to do androgen deprivation plus minus chemotherapy in certain situations. And then I'll talk about oligometastatic prostate cancer. We'll look at the available data on prostate-directed therapy in that setting. And we'll look at metastasis-directed therapy and also systemic therapy. So, for those of you who are familiar with this literature, you know that there are many, many studies looking at all sorts of approaches to castrating the patient, surgical and medical, and all the various durations of treatment and sequencing of treatment. And if you read all of these, there are still a number of unanswered questions. But for the purposes of this talk, this session, I think I'm just going to look at a couple of these studies that drive the current recommendations for androgen deprivation along with radiation therapy as the primary treatment. So this is the EORTC trial. This is the final report from 2010, so it's a fairly old study. And it looks at patients who are getting radiation alone and those who are getting radiation with androgen suppression. And as you can see, I'm going to go to the core of the data here. There is survival benefit. So this was the study that actually made this recommendation that you have to do androgen deprivation with radiation for up to 36 months. And if you look at the hazard ratio is 0.6, so 40% mortality reduction is impressive. And but who does this apply to? That's the trick here. This is a mixed group of prostate cancer patients. This was published in 2010, but the accrual really happened in 87 to 95. And a lot of these patients are Gleason 7 and 10 patients. I'm sorry, the number of Gleason 7 to 10 patients is about 32%. So a lot of these patients are low risk patients, but this is really looked at as a high-risk patient population based on those old definitions. So based on this study, for high-risk patients, we say up to 36 months. So then the question changed a little bit, looking at intermediate risk patients. At the time, there was data that suggested that 4 months of androgen deprivation improves survival along with radiation. And this could be done 8 weeks before radiation and then another 8 weeks during radiation and to completion of treatment. And the question became, okay, we know 36 months is good, is associated with survival advantage. Are we supposed to do more for intermediate risk patients too? And this study put, as you can see, over 1,500 patients to try to answer this question in a very unique way. They looked at doing 8 weeks of androgen deprivation before radiation, then another 8 weeks, or doing a longer period, up to 28 weeks of androgen deprivation before radiation, trying to see if more androgen deprivation is associated with better outcome. And this study was actually negative. It looks like the animations here are not working. So this study was negative, and if you look at the patient population here, this is supposed to be intermediate risk patients, but we have 10% of patients with PSAs of greater than 20. We have 10% of patients with Gleason 8 to 10, and we have about 15% of these patients in high risk category based on NCCN guidelines. So again, we now say for intermediate risk patients getting radiation therapy, we do 4 to 6 months of androgen deprivation, and that is deemed sufficient. This is the Kaplan-Meier curves for survival and time and disease-free survival. So as you can see, curves are overlapping, no significant difference. So at this point, really nothing beyond 4 to 6 months is indicated in these patients. So with the studies that looked at combining docetaxel in early metastatic disease, showing that there's significant benefit, this question always lingers in our minds that how about doing chemotherapy earlier in curative intent group of patients that are going to get androgen deprivation anyway, so why don't we just add chemotherapy and see what happens? And a number of studies have looked at this question. Scandinavian prostate group has looked at this, and JATUG, a European trial, has looked at this, and they have found that there's really no benefit. And this study, RTOG 052, is the outlier here, and we look at their data that suggests there may be a benefit, but let's look at what that benefit really is. So in this study, patients with high-risk disease, as defined in the eligibility box here, they were randomized to getting androgen deprivation, followed by 8 weeks of, for 8 weeks, then radiation, and then up to 24 months of androgen deprivation. And in this arm, patients also got 6 cycles of docetaxel, very much like charted trial. And the study actually showed that the curves separate. And so chemotherapy adds something, the p-value is significant. So this all looks very interesting. But the key here is that they were aiming for a higher size benefit. They were looking at to have a hazard ratio of 0.49. They were not able to get to that hazard ratio, and instead they got 0.69. P-value looks significant, and the confidence interval looks good. But this particular confidence interval is actually 90% confidence interval. It's not 95% confidence interval. So even though this study, which was published in 2019 in JCO, even though this study suggests there's a benefit, we don't really know who these patients are. So it's difficult to pick the right patient for this approach. So guidelines still don't recommend it. It's, if you have a really high-risk patient that you think you want to be very aggressive and you can get the insurance company to go with that idea, I think you could do it. But for all patients, I don't think we can recommend that. So what is the bottom line? For radiation and androgen deprivation, I think it's simple. We want to start 2 months before radiation with Lupron or another ALH-RH agonist or antagonist. And then we want to do 2 to 4 months of additional, totaling 4 to 6 months of androgen deprivation for glucose 7 patients. For glucose 8 to 10 patients, we want to reach up to 24 to 36 months. These days, I think most of us will just do 24 months of androgen deprivation with radiation. And the addition of chemo is not generally recommended. If you have, again, exceptional cases, I think you could look at the JCO paper and make a case. So I'm not going to talk about adjuvant radiation. In adjuvant setting, we mostly just look at messing data and say node-positive patients should get androgen deprivation. So I'm going to leave that conversation alone. But let's look at salvage radiation in patients whose PSA don't nadir or quickly comes back up. We are looking at salvaging these patients after prostatectomy. We want to look at radiation, and radiation usually was done without hormonal manipulation. But this study, which is an older study again, dating many, many years ago, was reported a couple of years ago. They looked at hormone manipulation using bicalutamide. So T3 patients or T2 patients with positive margins, node-negative patients, they were put on either radiation and placebo or radiation plus bicalutamide 150 milligrams daily. And bicalutamide 150 is 3 times the dose that we usually use. It's associated with a lot of side effects, not pleasant to take at all. Nevertheless, this study was able to accrue patients. Again, the patients had to have a PSA level that was not over 4 to be eligible for this study, and they had to have imaging studies that showed no evidence of metastatic disease to be able to consider it for salvage treatment. So this study was positive. It showed that there is survival benefit, OS at 10 years, 82% versus 78%. P-value was significant. There was mortality risk reduction. Overall, this changed how we deal with salvage situation in terms of androgen deprivation. Because the dose of bicalutamide is so high here, most of us that medical oncologists, they think, this is effectively castrating the patient, even though it's done at peripheral testosterone receptor level. So we use Lupron or an equivalent to that instead of using that high dose of Casodex because of the side effects. And in terms of duration, again, this just looked at 24 months. So if you really want to do it by the book, it's 24 months, but we don't know if shorter period is going to be less effective. So it becomes a discussion, conversation with the patient as to what the appropriate duration of treatment is. If you look at the subgroups in this study, one thing that is noteworthy is that if the PSA is less than 0.7, these patients did not benefit, and there is indications here on this forest plot to think that they may have actually been harmed. So in terms of side effects. So I think the ideal patient for hormonal treatment in combination with salvage radiation would be someone that has a high-risk disease, PSA of 0.7 to 4, or they have positive surgical margins. So that would be the ideal candidate for this type of approach. So a few minutes about oligometastatic disease. It's not a new concept, but many, many years ago when people started talking about this and tried addressing the primary or metastases, the outcomes were not good, so it never got any traction. But now that we have more tools, better treatments, that's resurfacing again, and we are spending a lot of time talking about it. So how do we define oligometastatic disease? I think if you look at most of the people that have tried to address this, less than 5 or equal to 5 and less than 5 seems to be the higher end of this range. And we want to have lymph node and bone metastases rather than liver metastases. I think if you have a liver metastasis, I think it's hard to really think that patient is in the same prognostic category as the patient that has maybe 3 bone mets. So this idea that there may be some benefit to addressing the primary or the metastasis or doing a systemic treatment, this comes from a number of studies. And in this table, we can see a few of these. These are population-based studies looking at retrospective data in large databases. And some of these provided radical prostatectomy or brachytherapy. They looked at patients that received those treatments as opposed to no treatment. And some of them looked at radical prostatectomy, IMRT, conventional radiation therapy, and no treatment. And any way you look at this, you see that intervention seems to change the outcome. These are large data sets. There's always selection bias and incomplete information, and it's hard to look at the database and really be confident that when they say node was negative, it was, or when they say we had just 3 spots, it's actually true. But this is a clue that dealing with the primary may actually change the outcome, as opposed to just treat this patient as a metastatic patient. So there is value to controlling the primary. This is not really conclusive, but it's an important clue. And when you look at numbers like this, there may be a slight edge to, instead of doing surgery, looking at radiation. And this may just be because radiation is less invasive as opposed to doing an open radical prostatectomy. But those are the types of questions that are not answerable by this kind of research, and so we're going to leave those alone. This is another table. So the question then becomes, okay, if there is some benefit to dealing with the primary, is there any benefit to deal with in treating the metastases? And then in this table, we see a number of smaller studies that looked at, in 40 patients, they found 64 lesions, and they looked at providing radiation to the metastases. And they report various types of outcomes in terms of duration and what they are actually looking at, whether it's disease control, PSA control, or metastasis control. But again, this seems to suggest that dealing with the metastasis may also have some benefit in terms of outcome. Again, these are small series, mostly looked at in a retrospective fashion. And so selection bias plays a huge role in all of this. But again, it's another clue. So STAMPEDE is one of the largest trials in prostate cancer that is ongoing. They looked at this question, not for oligometastatic disease, but for prostate cancer patients with metastatic disease. And they put an impressive number of patients on this study. So 2,000 patients got randomized to the two arms, treated as per standard of care as metastatic disease, or do the standard of care and add prostate-directed radiation. So in this study, go back, they had a stratification for low burden of disease versus high burden of disease. So this is where we're going to take a closer look at this result. So for all patients, they found that survival benefit, there is no survival benefit. So the conclusion for this analysis and this arm of the study is that, well, if you have metastatic disease, there's no point in radiating the primary. There is a little bit of failure-free survival benefit, but what we really want to see is survival benefit, not anything else. So we can't recommend radiation to primary for metastatic patients. But it gets interesting when you look at patients with low metastatic burden. In other words, when we get closer to the spectrum where we can start calling these patients oligometastatic disease, we start seeing that the curves actually do separate for overall survival, and the hazard ratio is very interesting. It's 0.68, and p-value is very significant. So another piece of the puzzle, we can't recommend it for everyone, but there seems to be some benefit to doing this for oligometastatic patients. So in this, this is another study. This is radiation directed at the primary tumor. It's a HORAD trial. And when they put 430 plus patients on the study, again looking at really standard of care arm, which is androgen deprivation, versus treating the primary using radiation therapy. And everybody to just, this just is here to show that everybody got all appropriate treatments, because when you're dealing with an overall survival endpoint, the subsequent treatments are important. You want to make sure that everybody is getting all of the appropriate treatments. So patients actually did get all of the appropriate treatments, and there is really no survival benefit. So p-value was not significant. The curves are overlapping. They go over each other a couple of times, but nothing meaningful here. So this wasn't really high volume, low volume, or oligometastatic. This confirms the general idea that STAMPEDE trial had, that you can't recommend treating the primary for metastatic patients. If you're going to even look at that question, it should be for really low volume patients and special situations. One of the more interesting reports in this area of research came at ASCO GU. This is an Oriole trial by a group at Hopkins. And they looked at stereotactic ablative radiation to oligometastatic prostate cancer. So they imaged these patients, whatever they could see, they radiated, and the randomization was 1 to 2. So 18 patients got observation, which is really a standard of care. 36 patients got the intervention, and they looked at their outcome, which was progression-free survival, and there's benefit to that. So this is another piece of this puzzle that it's a good idea to, if you're going to call anyone oligometastatic disease and you're going to have an intervention, directing it at primary and metastatic lesions seems to make sense. So Nothing conclusive. It's not really changing standard of care. Other studies are ongoing. There's a SWOG trial looking at treating the primary. We have studies at USC for prostatectomy and oligometastatic disease, primarily looking at quality of life endpoints to see if you prevent downstream obstruction or other local symptoms. But I think what we can say is that for oligometastatic disease, research is necessary. Treating primary alone seems to be beneficial, but likely insufficient. And treating metastases may be necessary. Imaging technology is an important part of all of this. As you know, conventional bone scan may not show a number of metastases. So if you're going to call anyone oligometastatic disease, which implies you're looking at 5 or fewer metastatic spots, I think we have to do high-quality imaging using a fluciclovine PET or a PSMA PET to actually have a good handle on the presence of metastatic disease. In Oriole study, they looked at, they had imaging correlatives, and they looked at patients on the intervention arm that had failure, and all of those patients had additional metastatic spots that were not identified initially. So that seems to be an important part of all of this. And I think at this point, I'm going to stop here. And before we go to the next talk about metastatic disease, I'm happy to take questions. Thank you. Stampede is what?
Is Stampede the largest trial?
Yes. Stampede is, I don't know how many patients they have. It keeps changing. Stampede is a platform trial. And they have many arms. I think they're now up to arm J. And they answer various questions as they come up. They create an arm for that question and try to answer. So it's an ongoing study, European study, very large. On this slide that I had at that time, they had over 4,000 patients. I think that number is higher now.
Yeah, because the others, they're very small number, like 100 patients, 130, the other one 50 patients, 18 versus 36.
Yes.
So it's difficult to have a
Yes.
draw a conclusion, really.
Exactly. Stampede wasn't designed to answer the oligometastatic question. They just wanted to know, well, we're enrolling metastatic patients, let's treat the primary, see what happens. And that question, the answer was, it's not beneficial, it's not associated with any benefit. But because they had this subgroup of low burden of metastatic disease, and in that group we could see a survival benefit, one could draw the conclusion that we are on the right track. It seems that addressing the primary may be an appropriate course of action for patients with low volume of disease, which of course overlaps with oligometastatic as we have defined.
Interesting, you mentioned the imaging, that we might have better imaging like fluciclovine and PSMA. These imagings, these tracers, they were designed for, these tracers, they were designed for recurrence. And we are using the primary for staging up front. There is always a concern that the prostate itself, the prostate cancer within the prostate actually capture so much of these ligands that you may still misclassify these patients. And the cover of Journal of Urology this month is interesting. 100 patients underwent PET PSMA prior to radical prostatectomy, intermediate and high-risk patients, 100. They did extended node dissection in all of them. This was to identify node dissection. To identify node metastasis. 40 patients had node metastasis, 40%. Out of this 40, only 40% of this 40 were actually identified by PET PSMA. So PET PSMA is still not identifying node metastasis appropriately in the primary setting. I mean, not after treatment. After treatment might be different.
That's very true. And even when you look at the sensitivity of, there was a talk at ASCO last year, the big ASCO, about PSMA and how best to use it. And in different settings, it has different sensitivities. It's different for PSA recurrence versus metastatic disease sensitivities are different. So all of those are valid questions, but I think for the most part, they are considered more accurate tools compared to the conventional bone scan. And calling a patient oligometastatic disease because a conventional bone scan was negative is probably not the best way to make that decision, because you could do a PSMA or a fluciclovine scan and see 6 of them, and that would just take that patient out of that category. So I agree with your comments.
In high-risk patient, they was using ADT and docetaxel, and now there are some people saying that you can use ADT and abiraterone, and they're very similar with less side effects. What's your thought about that?
Yes. Again,
¿Entendieron la pregunta? Hoy en día están usando el bloqueo hormonal y docetaxel, como él lo mencionó, en alto riesgo, que en bajo riesgo no había claridad si realmente tendría sentido empezar la quimioterapia temprana. Alguna evidencia decía que era bueno usarla ahora temprana y no esperar a usarla después. Y han dicho algunos que en vez de usar bloqueo y quimioterapia, ¿por qué no usar bloqueo y abiraterona, que era mucho menos tóxica que la quimioterapia? Por supuesto, es mucho más costosa y hay que usarla por 2 años. La pregunta es, ¿qué piensa él de eso?
So, in the interest of time, I think the short answer is probably abiraterone is better than docetaxel. And that may be just because if you look at the whole spectrum of this combination treatment, first docetaxel came in Charted study and Stampede, impressive data, 17 months overall survival benefit in castration sensitive setting for metastatic patients. And then Latitude trial the following year reported data that seemed to be insensitive to volume of disease. So the size of the benefit, especially in castration-sensitive settings, seems similar, but it may have broader applicability. And if you look at that question in the setting of curative intent, higher risk patients, docetaxel, as we looked at, has some data, same thing with abiraterone. So abiraterone may be having an edge there. But there are a number of other questions. How long would you do the treatment? Is it 12 months, 24 months? And what do you end up finding yourself? What kind of situation? Suppose you do 12 months of treatment with abiraterone, PSA starts going up, then you have put yourself in a castration-resistant post-abiraterone setting that may be M0. So it's biochemical failure in those settings could be difficult to interpret or to figure out what to do with the patient. But if you look at docetaxel, most of the time you just do 4 or 6 cycles, you're done. So unless you have a very rapidly progressive disease, you're not going to find yourself in that situation. So it's an interesting debate in both settings, in curative intent and castration-sensitive disease, but I don't think we have a definitive answer, especially in curative intent disease. So if you have a higher risk patient, you really want to be aggressive, you can consider docetaxel or abiraterone. Probably better to do abiraterone. So let's go to the next session. Excellent. So next I'm going to talk about metastatic disease. my disclosures. So here we're going to look at important developments in the past few years, and then I'm going to just touch on one interesting study that was presented at ESMO last year. So we always did docetaxel in late-stage disease when castration-resistant disease was progressing, and we did 10 cycles, sometimes more, with an expected median survival benefit of about 3 to 4 months. So that was the standard of care until in 2014, this trial was reported. The idea here was that let's move docetaxel to frontline, put patients on docetaxel within 3 to 4 months of androgen deprivation. The trial had a stratification based on volume of disease, which interestingly had really very little to do with the actual disease burden. It was a definition that they had provided. Patients had to have 4 bone metastatic spots, and at least one of them had to be extraaxial, or they could have a visceral metastasis, something in the liver and the lungs. And if they had a lot more disease in the lymph nodes, it didn't make the patient high volume. So that's the way the volume was defined. Patients in the experimental arm got docetaxel. The other arm did not get docetaxel and just got androgen deprivation. So huge difference. The size of the benefit was much larger than what we were used to in castration-resistant disease. This was a kind of benefit that we had really not seen in prostate cancer. So overnight, standard of care changed. And at that time, the idea was that everybody benefited. High volume disease patients had a larger benefit. I think everybody had an improvement of about 12 months in median survival, and high volume was 17 months. So the question was, is low volume group also benefiting, or they're not benefiting? At that time, during this presentation, they were not able to answer that question. But later, when they updated the data, it turned out that the low volume patients do not benefit, and therefore we don't recommend docetaxel for low volume disease castration sensitive patients. Again, high volume, low volume, a little bit of misnomer. It's really not truly reflective of the burden of disease, maybe of the risk, but not really the burden of disease. So this is who really benefited from the treatment. Old or relatively younger, they had the same benefit. Visceral metastases were also in the subgroup that benefited from the treatment, and high risk, low risk, or lower risk based on Gleason score. Again, everybody really seemed to benefit from it. So Latitude trial was also ongoing at that time, and later in the following ASCO, they presented their data. Here, the idea was, okay, we have a castration sensitive patient. We put them on abiraterone, 1,000 milligrams daily, plus prednisone, 5 BID, and we continue until progression. And that was the experimental arm. The co-primary endpoints, overall survival, and this study was also positive, and hazard ratio was very, very similar to what Charted had shown. If you look at the patient population here, the enrollment criteria were such that I think if you try to overlap this, 80 to 90% of these patients are going to be high volume type patients if you try to match it to Charted, but they had some low volume patients in this trial. So this added another tool to our armamentarium. And if you look at subgroups that benefited from the study, almost everyone benefited. ECOG-2 patients, probably not. And patients with lower risk disease, few patients. So it seems like there may be a signal that there's benefit, but this wasn't really powered to detect this kind of outcome in that particular subgroup. So overall, I think abiraterone is an excellent option for these patients. The trick here is, again, you do 6 cycles of docetaxel and you're done, and you can monitor the patient and see what happens in the future. This is continuous treatment for metastatic patients. So on the first sign of progression, not only you are castration resistant, but you have also lost abiraterone as an option in that setting. And now we know that there is cross-resistance between enzalutamide and abiraterone. So it poses a clinical question that I don't know if we really have a good answer to. The next interesting study was ENZAMET. So this was led by the Australian group. Christopher Sweeney reported it, and it was a positive study. So very similar setup. The question is castration-sensitive patients. We give them enzalutamide. What do we see? What happens? And this was the hypotheses were, they thought that it would prolong survival. And in this particular study, they allowed prior docetaxel charted style. So patients that got docetaxel then went on to get enzalutamide. And the question was, is that even more beneficial? Is the size of benefit even larger if we did that? And those are some of the questions they are answering by this, in this study. So the design, again, they had the stratification based on high volume, low volume. They allowed planned early docetaxel, and if that was the plan, patients got docetaxel and then went on to get enzalutamide. And a number of other things which are not central to our conversation here. So primary endpoint, overall survival, appropriately, and the secondary endpoints, the usual suspects, plus a number of quality of life instruments. And the typical eligibility criteria, again, they allowed performance status of 2, only if it was related to the cancer. And let's see what they found. So this is the primary endpoint. This is the curve for overall survival. And there is separation of the curves. There is benefit, p-value significant, hazard ratio 0.67 for the whole group. Very much like docetaxel, very much like abiraterone. All of these had the hazard ratios of 0.67, 0.68. So very interesting that this benefit for early treatment in castration-sensitive setting keeps getting reconfirmed by the trials that we do. So a number of other endpoints, time to PSA rise and time to clinical progression, again, advantage enzalutamide, and these are all statistically significant. So on the question of whether docetaxel patients also benefit, we start to see that there may not be a benefit for those patients. Even though if you look at the subgroup that got docetaxel, 500 patients, 71% high volume, so you would think these are exactly the type of patients you want to see. So this setup is really nice, and you see some progression-free survival benefit, but overall survival is not there. So this takes away the enthusiasm to, do docetaxel and quickly add enzalutamide to the treatment for the patient. But patients that did not get docetaxel, the benefit for progression-free survival is there, and overall survival benefit also there. So I think this is the most appropriate type of patient. If you look here, 37% of patients are high volume. So the majority are not high volume, but there's still benefits. So as opposed to docetaxel, where for low volume patients, the benefit wasn't there, there may be some benefit for docetaxel for enzalutamide in low volume patients, as they were able to show in their data. So this is the forest plot. This is the low volume disease group of patients, and there is benefit. So if you're going to treat a low volume metastatic castration sensitive patient, enzalutamide is a good choice. The data is more robust than what we saw with abiraterone. So again, looking at overall survival and disease volume in the group that got docetaxel, high volume docetaxel, yes, it crosses the line, so is not significant. So I don't recommend it for that setting. And they draw the same conclusions. There is benefit for all, and it's probably not the best option for patients that have already received docetaxel, so the enthusiasm is lower. Then we have Titan, again reported in ASCO 2019. This is similar setup with a very similar drug, apalutamide, for castration-sensitive patients. The interesting thing here is that, as we saw with enzalutamide, patients with low-volume disease had some benefit. But as we see here, the results are slightly different. So this is the schema for this study: castration-sensitive, distant metastases. They want to make sure that patients are on androgen deprivation. Prior docetaxel was allowed, and stratifications prior docetaxel, yes or no, was included. So they didn't really divide the patients based on volume status, or high volume, low volume, the way Charted had done it, but they have that subgroup in their data. Apalutamide was given to the intervention arm as opposed to placebo. So it was placebo-controlled. Overall survival was the primary endpoint. And they have this PFS2, which is a new endpoint that we'll be hearing more about, but I'm not going to spend time going over that. The idea here is that you measure the time from the beginning of your intervention, you go past your first progression, and you look to the next progression. You measure this whole time as PFS2, and you hope that your initial intervention has an impact on downstream treatment outcomes, and they are using that to draw our attention to the fact that apalutamide may be slightly better than, for instance, enzalutamide. There has been no head-to-head comparison. So this is the patient characteristic table. Well-balanced study arms, nice number of patients, 500 plus in each arm, and there is a survival benefit. And again, hazard ratio 0.67. It's very interesting how closely they follow this same hazard ratio, these different drugs. And so apalutamide is an option in castration-sensitive metastatic prostate cancer patient. The question is, which drug would you choose? It's hard to say that we have evidence-based data. It's what you read and what you believe, and it becomes the clinician's choice. But I will draw your attention to some parts of this paper. So these are not showing very well, but we'll look at this. Prior docetaxel, yes, benefit. The median is actually over 1, so favors no apalutamide. So if patient has had prior docetaxel, those patients probably are not good candidates for apalutamide. And if you look at disease volume, low volume patients, the benefit, there may be a hint of benefit, but it's not statistically significant, as opposed to what we saw with enzalutamide that had statistically significant benefit. So these studies are not really powered to answer those specific questions the way we want them to, but if you are going for the strongest data, my feeling is that enzalutamide has the stronger data here as opposed to apalutamide. This is the progression, radiographic progression, which these days we are liking it more than just PSA progression. In my clinic, I prefer to see radiographic progression before I discontinue or switch my treatment to another line of therapy. So this is, again, another interesting endpoint and is statistically significant. So in terms of prior docetaxel, again, we see if we have prior docetaxel, this is really, even though radiographic progression is not significantly improved in terms of disease volume, for both low and high, radiographic progression is improved. But then again, for these kinds of interventions, we are looking for survival benefit, not just secondary endpoints. So, so what we can conclude from Titan, high volume, no prior docetaxel, apalutamide is a good choice associated with survival benefit. So Alliance A031201 trial of enzalutamide versus abiraterone and enzalutamide in combination. This was, again, another question very much like the other two trials. What happens if we combine everything up front, and do we see additional benefit? And the primary endpoint was survival, appropriately, and these were patients in this particular study. Appropriately, they did not allow taxane therapy because they're combining two other treatments, enzalutamide and abiraterone, so adding taxane didn't make sense. So this is schema, enzalutamide versus enzalutamide and abiraterone together, 1-to-1 randomization, no benefit. So hazard ratio 0.9, didn't meet the pre-specified significance level, and that is not something we should consider for our patients in our practice. Any way you look at this data, if you look at PSA drop, however you look at it, the combination doesn't really offer much over just enzalutamide. This is radiographic progression-free survival, but that is not what we really are looking for. So this is a summary. So ENZAMET was presented in plenary session because the data was very impressive. and Titan study was presented at the same ASCO. Similar results. Again, the question of post-docetaxel or high volume, low volume. These studies are not designed to answer those specific questions. But if you look at the data, ENZAMET has better data for low volume patients, and neither study suggests that docetaxel patients treated with docetaxel will really have a benefit from additional treatment at that point in the course of the disease. We talked about cross-resistance between abiraterone and enzalutamide. We are seeing that more and more. If you progress on one, chances of responding to the other one is somewhere between 20 and 30%, not very impressive. So the question is, what do we do? Do we go to chemotherapy? And this is the study looking at a question like that. So patients that have had treatment with another androgen receptor targeting agent, it could be abiraterone, it could be enzalutamide, they were randomized to get the other one versus going directly to cabazitaxel chemotherapy. And this study suggests that there is a benefit to going to cabazitaxel in terms of progression-free survival. And if you look at this forest plot, it sounds like it looks like across all categories of risk, cabazitaxel is the better option for patients. There is a survival benefit too. So I think if you have treated patients with one of these androgen targeting agents and there is progression, and I think appropriate progression would be not just the PSA but radiographic evidence of progression, then I think you need to move to chemotherapy. Chances of getting any meaningful response by going to abiraterone over the other one is going to be smaller, and you may lose the window of opportunity to give patients chemotherapy. Thank you very much for your attention. I'm going to pause here, and I'm happy to answer questions. Microphone?
Thank you. So this, your last slide, cabazitaxel, what kind of patients were this? Because the curve is like in 2 years, like almost all of these patients died, right? Can you?
So this is really castration-resistant setting. These are patients who've been...
Oh, there's a castration-resistant.
Yeah.
Oh, I see. That's a difference.
Yes.
Okay.
Yes.
Got it.
So these are patients that are progressing on combination treatments. By definition, they're castration-resistant, and so outcomes are different. The expected survival is smaller.
I see. Okay. No, because you're presenting
yes,
castration sensitive,
yes.
sensitive, and the other one is like the patients, all of them die in 2 years. What happens? Okay.
Yes,
that's why.
yes. That the last study, the chemotherapy study, was for castration-resistant patients.
All of these drugs FDA approved?
Cabazitaxel is, apalutamide is, and enzalutamide is also FDA approved. Abiraterone is FDA approved. Cabazitaxel, I think usually we end up using it in post-docetaxel setting, but I think with this kind of data, you could just do it instead of docetaxel.
Or doing up front?
No, in castration-resistant setting, right.
Very interesting.
Thank you very much.